Good morning. Just testing.
Good morning. Good morning. Was that Jody?
Good morning, Gloria. Thank you. Just making sure I don't mic issues.
Yes. Thanks for joining us, Jody. We'll go ahead and get started. People are still being let into the meeting, but we have a number of formality type slides to go through. So we'll go ahead and get started. If you'd like to put your name and organization into the chat a while, please feel free to do that. But good morning and welcome to DDAP's Technical Assistance Webinars. And before we begin, I'm going to read the wiretap information. In accordance with the wiretap, it is against the law in Pennsylvania to record oral conversations without the permission of folks involved in most circumstances. This session is being recorded for training and/or record-keeping purposes, and by participating in this session, you're consenting to the recording, retention, and use of this session. So at any time, if you have a question or comment, feel free to place that in the chat, or you can raise your hand and we will respond to you as soon as possible. But please note that by doing so, you are consenting to the recording, retention, and use of your statements recorded as part of this session. So if you don't want to be recorded, please exit this call at this time, and you'll be able to review the video in its entirety on the DDAP webpage at some time in the future. So we'll go ahead and get started. We're going to discuss some of the guidelines. This may not apply 100%, but just a reminder about the ASAM criteria. Alignment with the ASAM criteria 2013 edition is required of drug and alcohol treatment providers. So that's just a disclaimer that everyone is expected to be using the ASAM and aligning with its criteria. Presenters for today's presentation are visible on the screen. We have Victoria Leahy, who's a national certified counselor. I'll do introductions as we go along in more detail. But we also have Samantha Zom, who's special assistant to the secretary at DDAP. We have Dr. Carrie Thomas-Getz, senior epidemiologist for the Department of Health, and Jody Skiles, who is the Program Licensure Bureau Director at DDAP. Before we get started with today's presentation, Amanda Madison from DDAP is going to ask some poll questions for today. So go ahead, Amanda, I'll hand it over to you.
Good morning, everyone. So on your screen, I am going to launch the polls. If yours is not working properly, please enter it in the chat. So tell us your role. Are you an executive director, clinical supervisor, counselor, administration, medical staff, support staff, case manager, DDAP, SCA, or FIMCO? Next, we'll ask, how do you feel about harm reduction services? A, I fully support any and all harm reduction efforts. B, I support forms of harm reduction in most instances. C, I support harm reduction around communicable disease transmission. D, I do not support any forms of harm reduction. E, I'm not sure how I feel about harm reduction. Looks like we have about 60-some% of you that say you fully support, 30-some% that say you support it in most instances, and about 3% that say you're not sure how you feel.
Great, thank you, Amanda. And thank you, everybody, for taking that poll. Okay, we are going to start with Samantha Zom, who joined DDAP in September of 24 as a special assistant, where she leads Pennsylvania's overdose program. And I will now hand it over to Samantha.
Good morning. A little bit about the overdose prevention program here in Pennsylvania. So DDAP partners with organizations throughout the Commonwealth to distribute naloxone and drug testing strips. So these tools are provided free of charge to help reduce harm and save lives throughout across communities. The organizations that participate in this initiative are referred to as overdose prevention partners or recognized entities, and they function as local access points where community members and organizations can pick up naloxone and test strips locally. So this is like a hub and spoke model, and it ensures broader reach to make these life-saving resources available. Next slide, please. So this is a map that shows rates of naloxone distribution per 10,000 people by county from October 23 to September 24 through the Pennsylvania Overdose Prevention Program. And this was when the program was under the administration of PCCD. And this includes all formulations of naloxone. So that was 4 milligram, 8 milligram, and intramuscular, and is reported by individual doses. So do note that the dissemination is based on organizations' requested shipping address. So for example, some of our SCAs that cover multiple counties and the physical location, for example, Franklin Fulton, the SCA is located in Franklin. So the Narcan is shipped to Franklin. So that's why it's showing that. We're working on getting better data so we can see where exactly it's going though, then after being shipped. So counties that are shaded obviously reflect their rate ranges. Lighter shades indicate lower distribution rates, while darker blues represent counties with higher saturation. So thanks to DOH, we worked with them to create these maps, and we also overlaid this with overdose death data maps to really get a targeted naloxone distribution. So we're working with them currently to continue these efforts. All right, go ahead to next slide. So where can you get naloxone? So individuals can get naloxone through a few different methods. First, we have a free mailing program for any resident in Pennsylvania. It's a partnership through Next Distra and Prevention Point Pittsburgh. So you can receive free naloxone through the mail. It's especially important for residents that are rural or underserved areas. Second, individuals, you can get free naloxone or other supplies through these overdose prevention partners or recognized entities. There are different options available, so like walk-in, pickup, delivery, and you can go to our website and there's a search hub and you can see what different organizations within your area offer these different supplies and what options are available. Lastly, obviously the pharmacy options, but unfortunately sometimes these options are not always free. You can get naloxone over the counter, or you can use a prescription and standing order. And we do have a naloxone copay assistance program here in Pennsylvania, and it's a $50 off. There's a link here in the slides, which is a great program as well. So next, I'm going to hand it over to Department of Health to review some overdose data.
Yeah, good morning. Thank you so much for inviting me to present. I don't have a ton of time, so I'm going to go through these pretty quickly, but I wanted to highlight some important trends. So here you can see some trends in any drug overdose deaths along the top and the opioid-related overdose deaths in the lighter shade of blue. In 2023, we saw nearly a 9% decrease in all drug overdose deaths in Pennsylvania compared to 2022, with a nearly 10% decrease in opioid-related deaths. Our 2024 data is still preliminary, but if we move to the next slide, you can see monthly trends through August of 2024. Due to the delay in death records for drug overdose deaths, we won't have a really good feel for full year 2024 data until later this summer. But while these decreases are certainly exciting, I do want to promote us being cautiously optimistic. If we move to the next slide, we can see that trends in non-fatal overdose are a little different. So if we look at monthly trends in overdose-related emergency department visits, the trends in 2024 are more similar to those seen in 2023 than what we're seeing in the death data right now, with only about a 1% decrease in any drug overdose-related emergency department visits and a nearly 5% decrease in overdose-related ED visits associated with opioids, indicating that overdoses in general are not decreasing as much as the deaths are. And seeing the decreases in deaths is really good news, but our trends do tend to differ by race. So if we go to the next slide, we can see in darker shades across the top that the any drug overdose related emergency department visits are still disproportionately high among BIPOC communities in Pennsylvania, with increases in non-fatal overdoses in 2024 compared to 2023 in any drug overdoses among Black and all additional race communities in the state. And then the overdose-related ED visits for opioids are seen across the bottom in the lighter shades, where they're still showing disproportional impacts among BIPOC communities. So though we do see a decrease in overdose-related ED visits for opioids among Black communities, we did see an increase among all additional races. Then the next two slides do show our 2023 and our preliminary 2024 counts by county. I just wanted to provide that perspective for those who are interested. If you want to move through the next two slides, you can see there are maps if people are interested. But if people are interested in more detailed data on both fatal and non-fatal overdoses in Pennsylvania at both the state and county level, you can go to the next slide and there's a link for our drug overdose surveillance interactive data report. And with that, I will turn it back over to DDAP. Thank you so much.
Thank you, everybody. Next up, Jody Giles, our Bureau Director of Licensing, will provide some information about our mobile units. Thanks, Jody.
Yep. Thank you, Gloria. Good morning, everyone. So just a couple of ways that the department has addressed harm reduction. A couple of other ways, not only through the overdose prevention, but through mobile medication units. We currently have 4 mobile medication units in Pennsylvania, which is amazing considering where we were prior to 2022 before the moratorium was lifted. Gudenzia Cold Township has recently, as of last week, received their approvals to add a second unit. Gudenzia was not only the first, but now they're the first with 2 units. I'll just describe briefly a little bit about what each unit does. So these mobile units with Gudenzia, they go to different counties. They're in the northeast portion of Pennsylvania, and they provide MOUD at those locations in the northeast. And that's an expansion. The second unit is an expansion of this. They are able to do physician service, counseling, and lab work. So it's really a full service unit. Marikey in Philadelphia, they were the entity that received the second mobile medication unit in Pennsylvania. They are for the Kensington area, and they not only provide medication, they also provide wound care, CRS services, and again, they can provide the full array of counseling, medical services, and all the required lab work. So they can do all their screens, their drug screens on that unit. And then most recently, Tediso in Pittsburgh has also obtained a unit, and they are doing the full array of services, which is medication, the harm reduction by going to different locations and providing naloxone. When they first did their soft launch, they went to the Free Store, which is Senator Fetterman's spouse, and I cannot think of her name off the top of my head, but they took that unit to the Free Store and gave out free naloxone, and it was a way of advertising, in a sense, this is available and this is something that you can do. So those are the 4 units in Pennsylvania that we currently have. And that's all I have. I could just share briefly, we've got medication units that are happening in the current one is Allegheny County Jail. And that is where they're able to go into the jail, provide medication to anyone that is currently on MOUD, or they can start MOUD for individuals. And if any questions about that, you can just ask me in the chat. Thank you.
Thank you, Jody. Thank you so much. Okay, next we have Victoria Leahy. Ms. Leahy is a therapist and, oh, whoa, sorry, you just took over my introduction, Victoria, but that's okay. That's okay. I can read it from my give me 1 second. Okay. Ms. Leahy is a therapist in private practice, providing group and individual therapy, as well as training and clinical consultation. She is an independent contractor for the state of Pennsylvania, providing training and professional development for DDAP since the late 80s. Ms. Leahy began using a harm reduction approach in her work in HIV and AIDS prevention, and as the director for client services for the Pittsburgh AIDS Task Force. Since the mid-90s, Ms. Leahy has provided training on harm reduction, both for DDAP and in her work as a national training and screening, brief intervention, and referral to treatment, also known as SBIRT. And just to make this day a little more special, it also happens to be her birthday. So we are especially grateful that that she's sharing her time and expertise with us today. So at this time, I will hand it over to Victoria. Thank you.
Thank you. I'm having a little bit of technical problems, so I want to make sure that everyone can actually see my PowerPoint. And if you heard a crash earlier, it was because my cat Sally decided to attack my desk during the presentation, but hopefully she's eaten and she'll be taking her morning nap.
Yep, I think we see a bunch of hands, thumbs up, Victoria. So I think we're good. Thank you.
The origins of harm reduction actually are in Amsterdam and Merseyside. And they began in the first opioid epidemic in the 1970s. And both the Netherlands and Merseyside have a different paradigm approach to substance use. And they took a public health approach as opposed to a criminal justice approach. And the reason why they did this is they believed that they weren't going to be able to eradicate drug use. Actually, the first legal sanctions against a drug were against caffeine in the 1600s. The Ottoman Empire, England, and France actually banned coffee and coffee houses because they saw coffee houses as dens of sin and sedition. And you can see how successful those bans were. So they believed they weren't going to be able to stop drug use. So their focus was on containing it. And they saw substance use as affecting health and well-being. And so their focus was on prioritizing the health and the well-being of individuals who use drugs. And their thought was, we want to reduce the harm that drugs do to individuals and their communities. And actually, harm reduction began as a response to the hepatitis B epidemic that was occurring among injection drug users in Europe. And they believed that focusing on drug trafficking and the manufacture of drugs was the best use of the criminal justice system. Their concern was that individuals who had substance use disorders would be marginalized. And if they were marginalized, they wouldn't have access to services, and they were less likely to be able to have the resources to stop their drug use. So their focus was on creating successful, life-enhancing services for people who were actively using. And they actually used the criminal justice system as outreach workers. So if someone was stopped for a traffic violation, they were given information about treatment services with the idea that many times criminal activity was linked to drug use, and that using the police as kind of outreach workers, they were going to be able to reach people that treatment had difficulty reaching. So the idea and the goal of harm reduction in terms of drug use was to make services available to people who use drugs so that they were able to draw on the resources that facilitate change. And if you think about historically, what's been problematic in this country is that often people on medically assisted treatment could not access housing. And we know that stable housing is a major factor in individuals' ability to recover from substance use. So the focus was on how do we make people as stable as possible. The more integrated individuals are in the community, the more likely they are to change. And the concern was, if we involve the criminal justice system, we're actually going to do more harm than good. We'll actually impede change rather than facilitate it. Lost my cursor here. Okay. So the model treats users with dignity. The belief is that individuals, even if they're using substances, are still capable of making responsible choices. I've worked in addiction treatment since 1980. And historically, there was this belief that if people were active users, they of course could not make responsible choices, which actually makes no sense at all. In order for individuals to survive while they're using substances, they have to be capable of making some choices. And when I've worked with people who actively use, I found that people make a number of responsible choices. When I worked at the Pittsburgh AIDS Task Force, we provided case management services to people who actively use drugs since the late 1980s. And one of the agreements we would make with clients is, when you get your Social Security check, how about if we take you to the bank, we make sure that your rent is paid, we make sure that your utilities are paid, and what you do with the rest of your check is your business. And we had a significant number of clients who agreed to do that. I have a friend who is a doctor in Washington, D.C., working with individuals with housing insecurity and who actively use drugs. She would tell her patients, I'm not the drug police. If you're using drugs, tell me what you're using so we can make better health decisions. And what she found was her clients who were actively using were rarely a no-show for their doctor's appointments. They would tell her about what drugs they were using. If she suggested that they not use before they were going to have certain medical tests done, they didn't use, and they would follow through with her medical suggestions. The model is person-centered. One of the things that we have 50 years of research that tells us is the best treatment outcomes are actually a result of the personality of the therapist. The personality of the therapist is actually the best predictor. That across all treatment models, we find that individuals with certain personality characteristics have much better treatment outcomes than those who don't. And a lot of this research arose out of client-centered or person-centered therapy. Motivational interviewing draws on that research. And Rogers was accurate that empathy, unconditional positive regard, and compassion are critical components in the therapeutic relationship. So the goal here is to embody the characteristics that facilitate change. And so many people doing harm reduction have adopted both motivational interviewing and focus on stages of change. We know from Prochaska and DiClemente's work on stages of change that if you do use an intervention that belongs to a more advanced stage of change, when people initially are contemplating whether they should stop their drug use or not, you actually impede change. And we're going to be talking about this in more detail in a few minutes. The idea is if I can assist or facilitate people in making any kind of change, that in turn builds their self-efficacy, their belief that they can make changes. And what we found in research on health behavior changes is the more self-efficacy that people have, the more likely they're going to be successful in making changes. And harm reduction has expanded well beyond looking simply at substance use. When I work with individuals with chronic health problems, I often use harm reduction. We fail to recognize that managing a chronic illness is difficult. Oftentimes, the various procedures that people undergo have harm. I work very closely with people in developing collaborative relationships with their doctors, because I often find that a difficult relationship with your healthcare provider actually adds to the harm of your chronic illness. And we know that the best predictor of medication adherence is the relationship with a doctor. Folks working with domestic violence use harm reduction. We know that unless someone has stable housing, removing them from their home actually increases their risk of violence. Unless someone has secure housing, you don't want to encourage someone to leave because you actually can increase the risk. So working with people around it until you're able to leave, how do we reduce the harm in your environment? I've worked with a number of folks working in the sex industry. Safer sex work is critical. Having someone know where you're going at all times. Having friends that check on you to make sure that you're safe. Meeting people in places that you have control are very important when people are doing sex work. In the last couple years, the workplace, particularly for individuals providing substance use disorder services has been fraught with harm. We've had a number of drug overdoses. We've gone through a COVID epidemic, and this has taken a toll on folks. And when we adopted a trauma-informed model, we did that in recognition that we're working with individuals with histories of trauma. And that not only impacts the individual we're working with, but it also impacts the staff. And a trauma-informed model attends to not only making services safer for clients, but also for the staff working with individuals. We've recognized that workplace can create harm, and how do we reduce harm in the workplace? The whole approach with HIV infection was to give people an array of choices. We recognized that if we told people to stop having sex, that wasn't likely going to occur. So, and many people weren't going to be using condoms. So we gave people kind of a buffet of choices to reduce their risk for HIV, and found that individuals were more likely to do something if you gave them an array of choices. And I use harm reduction with every client I work with, because the less stress in people's life, the more resources they have, and the more likely they're able to make any kind of change. And it's important to understand that harm reduction interventions fall across an entire spectrum. I think in this country, we automatically associate harm reduction with needle exchange. But we actually have a vast variety of harm reduction interventions. The designated driver program is a harm reduction intervention. We recognize that people are going to drink, and the idea is have someone who chooses not to drink be your driver. And that has substantially reduced alcohol-related accidents, traffic accidents. Operation Safety Net is a harm reduction focused on people who are housing insecure. Rather than expect individuals to go to a clinic, medical services are delivered to the individual wherever they are. And the idea, and often they distribute in cold weather gloves and socks, recognizing that some individuals are not going to be willing to go into shelters. And if they aren't willing to enter a shelter, what can we do to reduce the harm that comes with housing instability? Medically assisted treatment is a harm reduction approach, recognizing that many individuals cannot simply stop using drugs, and that MAT is an option that can help people avoid the harm that comes with drug use. Treatment is a harm reduction approach. So is pre-exposure prophylaxis. We have substantially decreased HIV infection by making PrEP available to people. When individuals take PrEP, it's 98 to 100% effective in preventing HIV infection. We had a nationwide hepatitis A outbreak in 2019. The vast majority of people who were infected were housing insecure. We reduced dramatically our rates of infection by simply vaccinating people with hepatitis A. Healthcare workers went to homeless encampments throughout the country and encouraged people to get vaccinated. And in 1 year's time, our number of cases dropped dramatically. In Pittsburgh, and other areas of the country, Narcan has significantly reduced overdose deaths. Safe injection sites, and I think sometimes people fail to recognize that not only is Narcan available at a safe injection site, but so are EMTs. And in addition, there are all kinds of resources that individuals are given related to detox and treatment. We find that as we establish relationships with people, again, that can facilitate them eventually receiving services. And often safe injection sites and needle exchange programs reach people that traditional treatment doesn't. And so we're connecting with a population that we often don't see in treatment. The Harm Reduction Coalition developed a safer injection manual, really telling people the safer sites to inject drugs. This is usually the harm reduction intervention that many people are uncomfortable with. But having worked with folks who inject drugs, I know that with opioid use, much of the damage that's done to individuals health-wise comes from injecting drugs. And by making changes, people can avoid damaging their veins. They can avoid wound site infections. They can avoid endocarditis. ESPER is a harm reduction intervention. It's focused not on people who are chemically dependent, but rather on individuals who don't meet the criteria for chemical dependency, but whose drug or alcohol use is harming their health. And this is a harm reduction approach. So I might tell an individual who maybe drinks 2 drinks a week, which is considered very low risk, but who has acid reflux, that when they eat Mexican food, they might want to not drink at all or only have 1 drink to reduce the likelihood that they'll experience acid reflux. If you look at the line graph, in 2017, Allegheny County, where I'm located, had the highest per capita overdose rate in the United States. And you'll notice by 2018, there was a sharp decrease. We dropped the number of overdose deaths by 42%. And we did it by distributing Narcan and training people in the use of Narcan. So you can see what a significant impact just simply introducing Narcan can have on drug overdoses. And if you look, you can see Prevention Point, Pittsburgh. We're distributing thousands of naloxone kits to thousands of individuals that it prevented or stopped overdose in 1,267 individuals. So you can see a significant change. In Illinois, 4 years ago, they had outbreaks. Excuse me, it's Indiana, not Illinois. They had outbreaks in small towns of 400 cases of hepatitis B. Some other town in 3 months would have an outbreak of 300 HIV cases. And at that time, they legalized needle exchange and saw a significant reduction in HIV, hepatitis B, and hepatitis C cases. Now, when is it appropriate to use harm reduction? Harm reduction is appropriate when we're looking at people in the early stages of change. If I were working with someone in determination or action where there was significantly more motivation to make a change, I would not do harm reduction in terms of their drug use. Because if someone's committed to making a change, it makes no sense to talk to them about reducing the harm related to their drug use. Harm reduction is an intervention that is relevant to pre-contemplation and contemplation when individuals have yet to make a commitment to make a behavior change. This is when we're still likely to see significant harm related to their substance use. And so the focus here essentially is keeping people alive until they make a decision to make a change, to reduce the health consequences they might experience until they make a commitment to change. So harm reduction is relevant in pre-contemplation, where someone is unaware or underaware there's a problem. Many of the individuals with whom we work are polydrug users. And it's important to understand that they may be in a different stage of change for each of the drugs that they're using. So I will often work with active users in my private practice. And I was working with a college student who periodically used cocaine, would engage in binge drinking on the weekends, and use marijuana daily. And she was in a different stage of change with each of these drugs. With cocaine use, she had some awareness that there was risk attached to cocaine. With her alcohol consumption, because this is something everybody that she went to school with did on the weekend, she was in pre-contemplation. So while I was working with her around reducing her risks for cocaine, she would go out on the weekends, drink heavily. She was on the south side of Pittsburgh at 2 o'clock in the morning, and she would have no idea where her car was. And for those of you who aren't in Pittsburgh, I don't go to the south side of Pittsburgh after 9 o'clock at night. It's dangerous. There's a lot of alcohol consumption. The city periodically threatens to remove the liquor license for all the bars in the area. And one of the things I focused on was her risk related to her alcohol consumption in terms of not knowing where her car was. Not having a safe way to get back to campus was where the highest degree of risk was. So I at one point said to her, I'm really concerned for you. Being on the South Side at 2 o'clock in the morning and not knowing where your car is isn't safe. You could get raped or you could get mugged. The next week when she came in, she said to me, I really thought about what you talked about. So I decided I have a friend who doesn't drink or will only have one drink when we go out. So I set up with her to go with her when we went out to clubs. And I texted her when it was time for me to go back to campus, and she drove me back to campus. And my response to her was, that's great. You did something to keep yourself safe. So this is a harm reduction intervention that you can do with clients who haven't been prepared to make a commitment to make a behavior change. It's also an intervention when people are in contemplation and they're ambivalent about making change. We know that if someone is ambivalent, if we push them to stop drug use, they push back in the opposite direction. They actually become more entrenched in their drug use. So again, I was working with a client who was smoking crack cocaine and drinking. And he recognized that there was a problem with his crack cocaine use. And we were really working on a pretty complex plan, not only to stop his use, but also to increase his safety around his environment, actually creating the resources that would make that possible. And while we were working, he got a DUI. And he was a baggage handler. And you can't keep your job if you don't have a license. So I said to him, on one hand, you don't want to stop drinking. And on the other hand, you want to keep your job. I said, you're in a dilemma. How are you going to resolve this? And he said, I'm going to give up driving, which he actually did. I'll take the bus. And again, my response was, that's a good choice. It'll keep you safe and it'll help you keep your job. So you can see with this intervention, I can help someone make a change even before they're willing to make a commitment. And the idea is, as people make better and better changes, what we see is that increase in self-efficacy facilitates them making other changes. Both of the clients that I discussed eventually were drug-free. We worked on making better and better health-related choices. And I watched them, actually, the client I was talking about who used cocaine, alcohol, and marijuana, also smoked. By the time she and I finished our work, she had stopped using cocaine, alcohol, and marijuana. And a year after she went back home, she emailed me to tell me she had stopped smoking. And for the first time in her life, she was totally drug-free. And again, it was by making better and better choices over a prolonged period of time. I made an effort to leave some time because I know some of you have concerns about harm reduction. So I wanted to leave an opportunity for you to ask questions or to share your concerns. You can do that through chat, or you can unmute yourself.
I don't think the participants can actually unmute themselves.
Okay, so do it through chat.
Or
Sorry.
you can raise your hand and we can also
Call on you.
identify you that way, or put it in the chat. And just while people are contemplating whether we're pondering any questions, one, the bridge between harm reduction and a clinical service, which I think you really did explain, Vicki, but could you just go into a little bit more detail about you're using the stages of change, and then you're also using motivational interviewing, and it sounds like you're tying the two together to
Yes.
utilize those clinical services and motivational interviewing to catch individuals when they start using that change talk and how they can evolve into the behavior change. Can you just talk a little bit more about that?
Yeah. The key here is we know the most important thing is to establish and maintain a therapeutic alliance. And essentially, motivational interviewing really focuses on doing that. But in order to maintain an alliance, you have to work with people where they are, as opposed to imposing your agenda on them. And the idea is if I'm working with people and I'm open to hearing them, and if they tell me, for example, they're not willing to stop a behavior, but they have awareness that if there's risk or harm related to it, they may be willing to address that harm. And as people make better and better health decisions, we see them moving more and more to healthy choices. And the goal here is if I have someone in pre-contemplation, I want to establish a relationship. If I tell them they have to stop drug use, I'm going to lose them. Or many of our clients have been involved in the criminal justice system. And one of the things they learned is if you want to get people off your back, you give them what they want. And historically, this is what they did when they were in drug treatment. They would tell you whatever you wanted to hear, and they would leave your office and then go and do whatever they wanted. What I find with harm reduction is people are more honest with me, which then increases the potential that I can facilitate change. Because I'm not telling you anything that you have to do. I'm helping you improve your life and improve the quality of your life. And we talk about recovery now, not simply in terms of stopping drug use, but we're talking about people creating a life that's worth living, that moving them more and more in the direction of life-enhancing choices. And I think that's at the heart of harm reduction, is I'm focused on improving the quality of your life. And I'm working with you where you are to make the kind of changes that are possible. In his work on stages of change, one of the things that D. Clementi points out that I think we often forget is sometimes people have difficulty making changes because they don't have the resources in the environment to support that change. So until I can help someone create or link to those resources, or to create an environment that supports change, harm reduction is something I can do to not only improve their health and well-being, but also to reduce the harm that accompanies drug use. And does that help answer your question?
Yes, thank you. That was perfect.
And, again, I'm going to argue that, and when I do this training, I always tell folks, you're going to at least leave today with some interventions that you're going to be comfortable sharing with your clients. Even if you're a drug-free program and committed to abstinence, I can give you interventions that you're going to be comfortable using. And I find that at the end of training, I have a number of people who tell me, I am taking stuff away today that I can use with clients. It is really important to see harm reduction as a spectrum, and that every one of the clients we work with have some degree of harm in their life. The more we reduce harm, the more resilient people are, the greater the probability that they're going to be able to make some change. And so I'm always thinking in terms of how can I increase my clients' resilience? And for someone who asked for my email address, I'm going to put it in the chat box.
I don't see any other questions. Go ahead. I didn't mean to interrupt you. We have about another minute or two. Were you going to say something else?
No, unless someone.
Don't see anyone. Any more questions? Any other? No training certificate for this. Sorry, we don't have credits, but I do want to thank everybody for being here today. Thank you so very much to all the presenters for sharing such valuable information. And a special thank you again to Vicki for not only being here on her birthday, but for your depth of experience and perspective that you brought to today's session. It was very, very excellent. Thank you so much. We appreciate everyone for attending and engaging in today's discussion. Before we close, just a quick note that our next webinar is tentatively, it is scheduled for next month, May 5th. It's Monday, May 5th at 10 o'clock. And our topic, we are planning on focusing on a provider's response to behavioral interventions. So we hope that you'll join us for that conversation as well. And until then, take care. Thanks again for being here and have a great Monday. Thank you, Vicki.
Thank you.
And everybody else. Take care.